Picture this. You walk into a clinic feeling completely normal. No chest pain, no headache, no dizziness, no warning signs at all. And within a few minutes, a blood pressure cuff tightens around your arm. A machine beeps, your doctor glances at the numbers, and suddenly your life is quietly reclassified with a sentence that sounds simple but carries enormous weight. You have high blood pressure. And in that moment, something subtle but powerful happens. Because although nothing hurts and nothing feels wrong, you are now told you are at risk. At risk of heart attacks, strokes, kidney failure, vision loss, heart failure, and early death. Conditions that sound distant and dramatic yet are now casually linked to your future. And this is exactly how millions of people across the USA and UK enter the world of hypertension every single year, often during routine checkups, insurance exams, or minor visits for unrelated issues, without realizing that high blood pressure is not a single disease, not a fixed diagnosis, and certainly not a one-size-fits-all problem, but a complex, fluctuating measurement that sits at the intersection of biology, lifestyle, psychology, stress, sleep, environment, diet, genetics, and time. And this misunderstanding is why so many patients leave clinics confused, anxious, and resigned to the idea that they are now chronically ill, when in reality they may simply have a risk factor that needs careful interpretation rather than immediate labeling. And this is precisely why, before accepting the label or starting lifelong medication, there are 3 essential questions every patient should ask their doctor. Questions that do not reject science, do not undermine medical authority, and do not delay necessary treatment, but instead strengthen the quality of care. Because good medicine does not begin with prescriptions, it begins with understanding. And understanding begins with good questions. The first question is this: how sure are we that my blood pressure is truly high in my everyday life? Because blood pressure is one of the most variable vital signs we measure, fluctuating minute by minute depending on sleep quality, anxiety levels, caffeine intake, nicotine use, physical activity, pain, emotional stress, dehydration, recent meals, posture, and even the temperature of the room. And for many people, the simple act of being in a medical setting is enough to trigger a stress response that temporarily elevates blood pressure. A phenomenon so common, it has a name, white coat hypertension, and decades of research from both American and British populations have consistently shown that a significant proportion of people diagnosed with hypertension in clinics have normal or near normal blood pressure when measured at home, or over a full 24-hour period, meaning that a diagnosis based on 1 or 2 clinic readings may not reflect your true long-term cardiovascular risk. And this matters deeply because once you are labeled hypertensive, that label tends to follow you for life, influencing future medical decisions, medication choices, insurance assessments, employment medicals, and even how you see your own health and mortality, which is why asking about repeated measurements, properly taken readings, home blood pressure monitoring, or ambulatory blood pressure monitoring is not only reasonable but explicitly recommended by guidelines, because these approaches capture your blood pressure while you live your real life, while you sleep in your own bed, move through your normal routines, experience everyday stress, and relax in familiar environments. Rather than relying on a snapshot taken in an artificial and often anxiety-provoking clinical moment. The second question you should always ask takes the conversation beyond isolated numbers and into real-world meaning. What is my actual risk of a heart attack or stroke, not just my blood pressure number? Because blood pressure does not exist in isolation. It is only one piece of a much larger risk puzzle that includes age, biological sex, smoking status, cholesterol levels, blood sugar control, kidney function, family history of cardiovascular disease, physical activity, body weight, sleep quality, mental health, and socioeconomic stress. and modern preventive medicine in both the USA and the UK now relies on validated cardiovascular risk calculators to estimate your actual chance of experiencing a serious cardiovascular event over the next 10 years. And when this broader context is considered, many people, particularly younger adults or those with only mildly elevated readings, discover that their absolute risk is far lower than they feared, meaning the potential benefit of immediate medication may be modest, while the downsides, such as dizziness, fatigue, reduced exercise tolerance, falls, electrolyte imbalance, sexual dysfunction, or kidney strain, become more relevant. And this does not mean medication is wrong, ineffective, or dangerous. It means treatment should be proportional to risk, because treating numbers without understanding context can lead to overtreatment, which is an increasingly recognized problem in modern healthcare systems, where diagnostic thresholds have gradually lowered, instantly turning millions of healthy-feeling people into long-term patients without necessarily improving outcomes. The third question, and arguably the most empowering one of all, is this: what can I realistically change in my daily life that would meaningfully improve my blood pressure? Because hypertension is one of the few major cardiovascular risk factors where lifestyle interventions can rival and sometimes exceed the effect of a first-line drug. Yet these changes are often rushed through, vaguely explained, or dismissed as unrealistic, despite overwhelming evidence showing that sustained weight loss, regular aerobic exercise, such as brisk walking or cycling, reduced salt intake, particularly from ultra-processed foods, improved sleep duration and quality, better stress management, reduced alcohol consumption, and smoking cessation can lower blood pressure by clinically meaningful amounts, sometimes within weeks rather than years. And when patients truly understand that their daily habits directly influence their blood pressure readings, something important shifts psychologically. They stop seeing hypertension as a mystery, internal defect, and start seeing it as a dynamic, modifiable process they can influence, which improves motivation, long-term adherence, and overall health outcomes. And importantly, asking about lifestyle change does not delay treatment for those who genuinely need medication. Instead, it ensures that medication is introduced thoughtfully as part of a broader strategy rather than as a shortcut or substitute for sustainable change, because pills can lower numbers on a chart, but habits shape arteries, organs, and decades of life. And the uncomfortable truth is that high blood pressure is too often treated as a binary diagnosis rather than a lifelong risk management conversation, even though both overtreatment and undertreatment carry real harms, especially in healthcare systems already under financial and workforce strain. And when you ask these three questions, you transform a frightening diagnosis into an informed discussion, shifting the balance of power from fear to understanding, from passive compliance to shared decision-making, because good medicine is not about blindly following instructions. It is about making choices with clarity, evidence, and responsibility. And if more people understood that hypertension is not a single moment verdict, but a long-term journey that requires nuance, patience, and perspective, we would see fewer unnecessary side effects, better prevention, stronger trust in healthcare, and healthier lives overall. And if you appreciate this kind of clear, calm, honest, evidence-based medical explanation that helps you ask smarter questions and take control of your health, then make sure you subscribe to MedLogic, because this channel exists to cut through medical confusion and give you the knowledge you need to protect your future with confidence.